I hope this finds you all healthy and well. I miss your faces as we transition to this kind of new normal. The first online lecture I wanted to post was basically a completion of our macular disease chapter, our macular disease lecture. We had gotten about halfway through ish, so this lecture will be covering sort of everything from that point forward. A quick note, if you haven't already sent me an update on the status of your assignments, and just a general update to let me know how you're doing, if you have connectivity, etc. Please do so. I want to find out sort of where everybody is before we move forward deciding on assignments and grading and things like that. So having that information will be really, really helpful. So if you haven't done so already, please let me know. So anyhow, we had left off in our macular disease discussion. I believe we had just finished talking about retinitis pigmentosa and Usher syndrome. So if I recall, we had left off talking about sort of the special considerations that you would need to have working with patients with both hearing loss and vision loss. As it relates to Usher syndrome, that is the most common syndrome that you'll see combining both of these factors. And so those extra considerations are very important. I believe we went through those, but I'm just going to reiterate some of the most important ones here. Let me just bring that up. So in terms of the symptoms, the signs and symptoms of retinitis pigmentosa, as we had talked about, being severe photophobia, tunnel vision, so a lack of a complete visual field, and in more advanced cases, central visual acuity loss. In the instances of patients with Usher syndrome, where they have a combination of both retinitis pigmentosa and congenital hearing loss, you have to sort of plan ahead a little bit as you're taking photographs, because as we had talked about before, folks with RP or really any rod cone dystrophies don't recover from the photos as do other people. So it can be very disconcerting for them to have a loss of vision that takes several minutes to recover from. Even in the fellow eye, it can be very disorienting. And so you want to work out in advance. You want to warn those patients in advance that they may not see anything out of that eye, that it will recover, but also to work out sort of a method of communication in advance, particularly if they utilize a sign language interpreter, because they may not be able to see their sign language interpreter. What I typically do with these patients is I show them sort of a system that I use, which is to tap the sides of their face, or to tap their forehead, for example, if I want them to look up, to tap their temple if I want them to look to the side, and maybe to tap their chin twice if I want them to blink. And so that seems to work fairly well. And not only that, it gives them a certain comfort to understand sort of what's going to happen, what they should expect, and that they have something to do. They have something to sort of work through and instructions to work through it. So that's really important in advance of actually taking any photographs. And you want to do that with the room lights on, because they have very poor night vision as well, and they will not be able to see the sign language interpreter even before you take photographs very often in a low light situation, because their night vision is poor. So again, that's just a review. I think we had already gone over that, but I wanted to reiterate it because of how important it is. So the next topic of RPE disorders that carry over into the macular region is ocular histoplasmosis syndrome. So ocular histoplasmosis syndrome is caused by fungus called Histoplasma capsulatum, and I'm probably butchering that pronunciation, but this is a yeast-based fungus found in the soil, specific to a particular region in the United States, in Mississippi, Ohio River valleys in particular. In fact, that's part of the differential diagnosis, is to ask patients if they have been to those regions in recent history, either in their recent travel history. This fungus can be carried on poultry as well. So if somebody has chickens, particularly if they've been shipped from those particular regions, since chicken raising is becoming more and more popular, it's certainly more likely that somebody has been in contact with chickens, as well as the droppings of infected bats, which is a little more rare to come in contact with. So it's not an uncommon fungus. Certainly people who live in this region or have these risk factors test positive for a skin antigen test for this fungus about 60% of the time. So it's not terribly unusual to have been exposed to this fungus. It's more unusual to demonstrate symptoms as a result, specifically in our case, ocular symptoms or ocular complications. And those typically occur in only about 1.5% of the individuals who test positive. So it's not super common, and it's not well understood as to why these individuals necessarily these particular individuals develop ocular complications, but it is a more rare complication of this fungus, of this fungal infection. The manifestation in the eye is punched out lesions in the retinal pigment epithelium and chorioretinal scarring in the periphery. So you'll have these very sort of singularly characteristic scars, these punched out holes in the RPE. For whatever reason, the fungus attacks the RPE specifically and creates these sort of punched out lesions. Now, if these punched out lesions occur in the periphery, it's very likely that the person may never know that they have them, may never know that they have these lesions or these scars or even the infection. So these are often found on typical examination, on typical retinal examination. The exception is if one of these lesions occurs on or near the macular region, because obviously that would engage their central vision and that would be much more noticeable from a patient perspective. Of course, the risk of those individuals who develop one of these scars at the macular region is that the macula will be compromised, and then they will be at much higher risk for developing a choroidal neovascular membrane. Again, remember, anytime the RPE is compromised, that outer blood retina barrier is compromised near the macula, that significantly raises the risk of that person developing a choroidal neovascular membrane, which is obviously detrimental to the central vision. And so that's much more of a emergent concern as compared to the peripheral lesions that might be a part of this syndrome. You may also see sometimes this syndrome called presumed ocular histoplasmosis, or POHS, instead of just OHS. They just recently dropped the presumed from the nomenclature for this disease, largely because, it's if it looks like OHS and it acts like OHS, it's OHS, as opposed to, well, I don't know that this person has been in this region, and so I can't say for sure. So it's just sort of a point of distinction that's happened in the last few years, that you don't typically see the presumed on there anymore. That's an older term. And that's really, again, it's presumed only if they can't trace that person's whereabouts to the affected areas. That they've sort of dropped that as a naming convention. So this is what it looks like. So you have sort of these punched out lesions in the periphery. And so these tend to be sometimes pretty far out, and they'll be varying in size and shape. Some are newer, some are older. The fungus is active in this particular eye, and so these newer scars that are forming are more yellow, whereas the older scars, the older punched out lesions, have this central sort of RPE hypertrophy at the center with the ring of RPE atrophy around it. So these are all areas of RPE compromise. So these lesions in the periphery, the person probably will never notice the effect on their vision because the other eye sort of, even though the other eye is affected and infected, it's unlikely that they would ever notice that as a part of their vision since the other eye sort of cancel each other out. I also want you to notice that in the RPE, in any RPE lesions, because they're so deep, the larger vessels will be on top of it. So that sort of gives you an indication as to how deep these scars are. So in this person, in addition to them having the peripheral lesions, they also have a couple of central lesions, one around the disc, which is a little more unusual. But then the one that we're really focusing on in the context of the discussion of macular disorders is this one right in the macula. And for this individual, that has manifested as a choroidal neovascular membrane. So a fluorescein on this person would show significant amounts of leaking in that region, in the macular region. You might be able to see a little bit of RPE modeling there if you look closely. So that individual has developed that complication as a result of one of those punched out scars, punched out lesions being right near the macula. By the way, I want you guys to, I will start to set up discussions on my courses relative to the particular lectures. Then I'm going to post for you to ask questions, for us to discuss and post. If you find any images that you're wondering about, things like that, that'll be a place for us to sort of do a post lecture discussion moving forward. I'm holding off right now on sort of real-time discussions until I hear from you guys, until I know for sure that that's something that is doable and that you have the resources to support. So again, please, if you haven't done so already, please get in touch with me to let me know if you have that 11 to 12 time slot on Wednesdays open, and if you would be able to participate in a Zoom call. Keep in mind that a Zoom call can also be phone only, audio only, and you can call in with your phone, but also in terms of an online Skype-like sort of meeting as well. We could also do a chat. I'm happy to support that as well, but I want to hear from you guys as to what would work best for you. So moving on to lattice or myopic degeneration. So lattice degeneration really only happens in individuals with significant myopia. So when we're talking significant, we're typically talking upwards of nearly double digits in myopia, -6 diopters or more. And this level of myopia can cause degenerative changes, and these changes can look like thinning in lots of different areas of the retina, but particular to the RPE. Because if you sort of imagine normally what should be a membrane that covers a ping pong shaped orb, in myopia, that same membrane has to cover a football. And so that football shape is very difficult to keep sort of adhered in the right spot. And there's different areas that can be prone to thinning as a result. So in myopic degeneration, the patients with this experience a thinning of the RPE, particularly in the periphery. So it's very important to chronicle the peripheral region in these people to make sure that to look for any signs of this lattice degeneration, which I'll show you pictures of in just a minute. They'll also have flattening of the disc, so the disc will start to look very two-dimensional. It will stop having that sort of cupping that we normally associate with disc anatomy. And this is specific to these individuals, and it's not necessarily something that is always like that. It's something that happens over the course of their lives. So that's why it's considered a degeneration, because as these individuals age, you see more thinning of the RPE, you see more flattening of the disc, you see increasing risk for retinal detachments, retinal tears, as this membrane sort of gets stretched over the years. It can break, it can tear, it can detach. And so anybody who's highly myopic, it runs a higher risk of all these complications. In addition to that, because there is a thinning of the RPE, a progressive thinning of the RPE, I'm sounding like a broken record, but if there's a thinning of that RPE around the macular region, they also have a significant risk of choroidal neovascularization. So it's this sort of collection of signs and symptoms that are specific basically to the shape of these individuals' globes. So I wanted to look at, just very quickly, first before we do that, sorry. This is choroidal neovascular membrane in myopic degeneration. So first, so I think we all in class have seen, just based on photographing your partners, you've seen in people who are more myopic, it's a lot more challenging to get everything in focus all at the same time. So it tends to be fairly obvious, especially the more experience you gain in the field, as to who's myopic and who's not, because the focus is really, really challenging on somebody who's myopic. But you'll also start to notice these other characteristics of people with high myopia, this flattened disc, this peripapillary atrophy. So there's that flat disc. You can see how it looks like it's just been kind of mushed into a single dimension. Peripapillary atrophy is common in people, even with minor levels of myopia. A bit of peripapillary atrophy is common, and that's just where the retina starts to pull away from the edge of the disc. In this individual, because their myopia is so severe, they've got a significant level of peripapillary atrophy, and so that's literally the retina sort of pulling away from the edge of the disc. Again, doesn't really affect vision because that's the anatomical blind spot anyhow, but it's something that is sort of a characteristic of these individuals. So this person has a choroidal neovascular complication as a result of their myopia. And so the RPE has thinned in and around the macular region, and it's provided the opportunity for this fairly significant choroidal neovascular membrane to pop up through the choroid, or the RPE rather, and grow and take up a pretty significant amount of space. And so this density here is the membrane plus a little blood in this vertical OCT. You've also got some pockets of fluid. You can see how disrupted the normal morphology is of the retina. So this person has significant visual acuity loss as a result of this neovascular membrane. And you can see just by looking through the individual scans in this crosshair that there's more abnormal than there is normal. And so this person has very poor acuity at the moment. So lattice degeneration is not something I have a lot of pictures of in the book, but I wanted to show you guys a little bit about what that looks like. It looks like retinal thinning in the far periphery where the vitreous adhesion is strongest. This is, again, most common in high myopes because they have the thinnest retina, so they have the most accelerated degeneration in this region. But really, anybody who's highly myopic will be screened for this, and they'll do a retinal exam that's really focusing in that peripheral region to determine whether or not they're experiencing any of these lattice sort of characteristics. When somebody has lattice degeneration, obviously that puts that individual at higher risk for more complications, including retinal holes, detachments, tears, but it's something that's watched They typically come back every year or so to get monitored for the lattice and to see how far it's progressed. So I'm going to exit out of this. I'm going to show you a little bit about what that looks like. And so lattice images are typically pretty bad from a quality perspective, just because you're way out in the periphery. You're almost at the ora serrata. So these are really the advent of ultra wide field technology has made it a lot easier to follow these patients, because with a standard fundus camera, it can be extremely challenging to get that same sort of positioning, especially each time they come back, because to get this far out in somebody's retina, like an example, this one here, to get this far out, it requires a certain sort of flexibility on the part of the patient, their eye muscles, basically, to be able to reach that area. And that, combined with sort of your ability to tilt your camera and to swing it and to get as far out as possible, and you can do things like having them turn their head a little bit in the headrest, so that you can avoid their nose, as an example. Those are all tricks to kind of get in that far periphery with a standard fundus camera. But with an ultra wide camera like an Optos, let's see what this brings up here, like an Optos device, you can get a much broader perspective, for lack of a better description, of the extent of somebody's lattice. And so it's also sometimes called snail tracks. I guess that alludes to like the slime that snails leave when they scooch along, I guess. I don't really know. But you'll hear that term sometimes bandied about. But lattice can also have this, let me go back, this kind of blackened center to these snail tracks, indicating RPE damage as that retina is thinning, as the RPE is thinning. So it can have both of these looks. It can either be this sort of whitish type of track, or it can have this sort of black centered on top of the whitish sort of thinning and scarring. Sometimes you'll also find a hole along with the degeneration itself, or the lattice itself. You can find a retinal hole. And so catching these early, this won't create necessarily any symptoms for the patient, although sometimes they might experience flashes of light, for example. But catching a hole like this requires that will send somebody for immediate treatment to try and patch that hole, so that it doesn't progress to a full detachment and it doesn't get any larger. But that's happens sometimes when you're photographing. You'll just catch the hole before the patient necessarily notices that issue. And there's many examples. So if you just Google lattice degeneration, there's many examples of, this is a fantastic stereo pair of lattice with a retinal hole, a retinal tear. There's several stereos within this particular resource is the Retina Image Bank, American Society of Retinal Specialists. And so if I haven't mentioned it before, and I'll also post this on my courses, this is a great resource to sort of look at additional images, because as we're going through all these different kind of disease processes and looking at examples, there is such thing as a textbook example, and that's often what I've tried to include in the book and in these discussions. But certainly looking at other examples is really helpful too, because things can sometimes look a little different. They can be atypical. They can be combined with other diseases and other signs and symptoms that sort of muddy the waters and aren't as clean as our textbook examples are. But it's still helpful for you to gain some kind of visual familiarity, some kind of pattern recognition with these different signs and symptoms, because they're they do present differently depending on the person, depending on what other diseases they may have, what their pigmentation may be, etc. So it's a really good thing to sort of get that familiarity. The other thing I wanted to point out too is sometimes if the lattice, if the lattice generation is very advanced, sometimes they'll lay down some laser spots to sort of treat that area, to try and tack it down, basically. So there's that option for treatment, but most lattice is sort of a watch and wait and see how it goes before treatment is done. Okay. So that's all I have for now. Again, just one more plea for you guys to get in touch. Let me know how you're doing. Let me know if getting together in real time would be possible or not. And again, the goal was to try to do that Wednesday. But I hope to also have more content up by then. For now, I would look forward in terms of reading to chapter 16. I'll post this also in the weekly content. Chapter 16 on vitreous disorders is our next topic that we're going to tackle. So in the meantime, I hope everybody is well and healthy, and take care.